Yeah, very good evening to everyone. Thanks to ISA Metro City Kolkata as well as Dr. Krishna Poddar for inviting me for this talk. So I'm supposed to talk on anesthesia for the cardiac patient undergoing cardiac surgery. And my specific topic was a 70-year-old gentleman who's being posted for surgery, which is a CABG. So I decided to come up with a scenario where, because especially I'm talking to the students, uh, I thought, giving them a scenario which they can relate to, which probably help them understand better. So this is a scenario where a 70-year-old gentleman presents with a history of off and on chest pain. He has a 20-year history of hypertension controlled by Prolomet XL, Telmisartan 40, and Stamlo 5. He has a 15-year history of diabetes, which is treated with oral hypoglycemic agents. And very recently, the OHS could not control the sugar anymore, and his GP started him on insulin, with which the sugars are controlled as of now. He has a history of ischemic heart disease, which was diagnosed 3 years back. And 1 year back, his chest pain was aggravated, and he went to the cardiologist, and angioplasty was done with a drug-eluting stent in the LAD. And he was, from that time, was on double antiplatelet therapy, clopidogrel A. Of late, his chest pain was increasing, and so went back to his cardiologist, and angiography was done, and a severe TVD with 80% left main disease was diagnosed. His blood work is fairly within normal limit, except borderline raised creatinine, although he passes fair amounts of urine, never requires dialysis. Incidentally, he has a TSH of 15, although his free T3 and T4 are within normal limits. His social history, he has been a heavy smoker with 20 cigarettes per day for 30 years. Quitted 3 years back when he was diagnosed with this ischemic heart disease. He can currently walk up to 2 kilometers because he walks to the bazaar, which is 2 kilometers away. But after 1 hour, 1 kilometer of walking, he needs he feels that he will need to rest because he feels breathless, and sometimes some chest discomfort, which goes away once he sits down at the local tea shop, Chai Ka Dukaan, and after he's seated for 5-10 minutes having a cup of tea, he goes again. That has been his routine for last 2 to 3 months, and he sometimes feels breathless, especially with exertion. One of them was walking to the bazaar. Also, climbing stairs, he feels he's a little bit having discomfort and breathlessness. And he needs off and on bronchodilator puffs. And on asking whether a diagnosis of COPD was made on him, he could not conclusively say. His GP did not say anything. Probably this is the area where he needs to be examined before the patient is taken for the operation. Pulmonology referral should be given. Now, on physical examination, he is quite well built, 85 kilos, and his height is 156 centimeters. His BMI is 34.9, which is mildly obese. He has a short neck with some loose and missing teeth. He has mild limitation of neck movement. On echocardiography, he has a LV ejection fraction of 40% with a regional wall motion abnormality with basal and mid anteroseptal walls seem to be hypokinetic on 2D echo. He has a grade 2 diastolic dysfunction and a PSP of 50 millimeter of mercury. That's a peak pulmonary arterial systolic pressure of 50 millimeter mercury, which is telling you that he has a pulmonary hypertension, which is significant. And he also has an incidental finding of a bicuspid aortic valve with some degree of calcification, with a mean gradient across the valve of 28 to 30 millimeter mercury, which stamps it as a mild aortic stenosis. Now, how do we plan anesthesia for this particular patient? So, this is briefly, this page would probably give you the idea of how we plan. So, the first thing is assessment of risk for this surgical patient, which is risk stratification. Just a moment. Yeah, okay. So, once we stratify the risk and come up with an idea whether he has a mild, moderate, or severe risk, we would plan, optimize the patient and plan accordingly. We will then plan about the conduct of anesthesia, whether he would undergo thoracocapital awake cardiac versus the general anesthesia, whether the different cafeteria choice of monitoring tools like invasive arterial lens, CVP, PA catheter, a CCO or a TE, which one or more is necessary. We'll discuss about that. And then we'll talk about choice of anesthetic as an induction agent and the choice of anesthetic as maintenance, whether a combination of inhalation and Tiva or either of them would suffice. We'll talk about anesthesia during cardiopulmonary bypass or CPB. And we'll also talk about the hemodynamic management. If the patient goes unstable, how do we diagnose the instability, and what are the tools that we use in that particular scenario? Perioperative echo, which is transcerebral echo that we use in the intra-op period, has a tremendous role. And eventually talk about a CABG and anesthesia, and CABG patients should actually finish with a follow-up in the post-op ICU. But I think because of the time limitation, we might not cover that part. And for today's topic, I would actually talk only about the anesthetic part of this 70-year-old gentleman who basically is undergoing a CABG. So coming to the risk stratification. So these are the 6 modalities or different methods by which I assess risk for my patients. So ASA classification, NYHA classification, MET score, frailty score, CARE or the cardiac anesthesia risk evaluation score, and the Euro score. So why do we need such elaborate risk stratification? The goal is, of course, to categorize the patient into mild, moderate, or severe, as I mentioned before. The higher the risk, the higher the morbidity in terms of prolonged ventilation, prolonged ICU stay, sepsis, shock, acute kidney injury, and the need for dialysis, perioperative MI, mortality, and so on. A framework to objectively explain the patient relatives, the risk calculated using a universally accepted tool like the Euroscore, especially the Euroscore 2 currently, has a huge medical legal significance. So a lot of our patients, especially these days, people Google so much, and then they are very aware of risks also. So they would ask you, what is the doctor? What is the mortality chance in our patient? So you have to give them an objective assessment. And one of the very good tools for objective assessment of mortality is Euroscore 2. So I'm going to discuss that. Now, starting with the ASA classification, from the history that I have given you, where does our patient, this 70-year-old gentleman who is diabetic hypertensive, who can walk a mile before he has a chest pain, where does this patient fall in this ASA classification? So, is he ASA 1, 2, 3, 4, 5? So, of course, ASA 6 is a brain dead patient, which we omit. He is also not a normal healthy patient. So, ASA 1 is omitted. So, is he having a constant threat of dying? He has a on and off chest pain, but if he sits down, the chest pain goes away. That proves that it's a stable angina. So, our choice remains between where he could be a ASA 2 or a ASA 3. But the question is his disease mild? His diabetes and hypertension was well controlled before, but of late he's requiring insulin. He also has a history of roughly a year back he had a stent into his LAD, and because he has 40% ejection fraction with the anterolateral ischemia, with a 40 because of the 40% MI, 40% ejection fraction in a patient who has diabetes, it could be a silent MI, And so all this together, makes him into a ASA3 patient. So he has a severe systemic disease, which is not at present being a constant threat to life. So with that, let's progress, and we'll try to find out the NYJ class he belongs to. He has only mild symptoms, mild shortness of breath, and or angina, and slight limitation during ordinary activity. So no doubt he is class 2 NYHA. His MET score, as you see, he cannot do vigorous activities. He cannot, he's doesn't go to the bazaar jogging, right? And nor does he cycle. So he can slowly slowly go to the bazaar, strolling at a moderate pace. After 1 kilometer or so, he gets tired and sits down. So his MET is less than 3. The frailty score is, if you try to find out where he belongs in the frailty scale. So a very fit individual is a frailty scale of 1, and a terminally ill patient or a very severely frail patient is a frailty score of 8 and 9. For him, he is not confined to the indoors, like frailty 5 to 9 are confined to indoors. Our patient, can go to the bazaar himself. This is quite independent, although slow. He does not exercise all those. Basically, he falls in a category of frailty score 3 and 4. Next is a little more focused evaluation regarding cardiac anesthesia risk provided by the CARE, or the cardiac anesthesia risk evaluation score by the Canadian Society, and the Euroscore, which is the European Association of Cardiac Surgeons. So we'll start with this, the CARE status for him, the CARE risk evaluation score, which is it basically gives 5 categories, so 1 to 5, and E for a patient who's undergoing emergency surgery. So a patient with a stable cardiac disease with no other medical problem is a score of 1, and undergoing non-complex surgery. So only one procedure, only CABG, no AVR or no MVR along with it, no endarterectomy, no complicated surgery, otherwise a stable disease. In this patient, our patient actually has a bicuspid aortic valve, and needs to be evaluated whether he actually needs a AVR, which probably he would, as we'll discuss later on. And he also has ongoing chest pain, off and on, which has become worse than before. He has more requirement of insulin. So altogether, so he has an uncontrolled medical problem, and he might undergo a complex surgery, which is any of these. So reoperation is not true for this, but a combined valve and coronary artery surgery. So he might require a AVR with a CABG, and his vessels might be bad. He might require an arterectomy. So overall, this patient falls as per this evaluation score in the category 3. So he is a CARE category 3 patient. Coming to Euroscore. Now, Euroscore evaluates the patient on the basis of multiple factors and criteria. Age being one of them. Female gender has much more chances of morbidity and mortality compared to males, especially for ischemic heart disease. A higher creatinine, extracardiac arteriopathy, chronic obstructive lung disease, neurological dysfunction, previous cardiac surgery, recent myocardial infarction, LVF as they regress from 50% to 30% and down, having bacterial endocarditis, and so on and so forth. So there are multiple factors on the basis of which the Euroscore evaluates the patient. So this is the previous version of the Euroscore. This is the additive or the logistic Euroscore. The current interfaces like this is very, very interesting. In fact, you just have to sort of click, just put in age and feed in the data. A male patient versus a female patient. A female patient has more risk factor for ischemic heart disease, as I mentioned before. And you can calculate the renal impairment in the same page if you scroll down. I'll show it later. And then our patient does not have, extracardiac arteriopathy. He does not have poor mobility. Does not have previous cardiac surgery. He might have a COPD. So I click yes. he does not have active endocarditis, and so on and so forth. He is on insulin. Right before he came to us, he required insulin, which was uh, started by his GP. He was an NIH. He's an NIH class 2. He does not have a resendamide, which is less than 3 months, and his LV function is around 30 to 50%. So each of these factors would give you a score, and the system, once you finish the survey, it will give you a mortality risk. So this particular patient has a mortality risk of 4.69%. Normal, a patient otherwise, with stable patient without much comorbidities would have a less than 2% mortality undergoing a CABG for European and American standards. So this is a fairly high risk factor for a patient undergoing CABG. I was just trying, anyway, before going to the next patient, I will just discuss if this patient was an 80-year-old female patient with the highest risk of everything: poor mobility, previous cardiac surgery, COPD, endocarditis, with NIH class 4, very poor LV, severe PH. If I put all bad things together, the mortality increases to 98.8%. So the idea is, it's a very objective way of telling the patient relatives. You can sit down with the patient and the patient relatives before your computer screen and tell them objectively that this is the reason. It is not me telling, but this is the software from the European Association of Cardiac Surgeons telling you that the mortality is pretty high. So you have to believe in that. And this also provides, interface where you can calculate the creatinine clearance. So you can multiply your, say, 1.4 into 8.8. A patient had a creatinine clearance of 1.4. You multiply that by 88.4. It converts into millimole. His age is 70 years, weight is 35 kilos, he's male. So the creatinine clearance is 59. And you can use that over here. And altogether, as we mentioned, here the mortality of 4.69%. So it's a very good tool for risk stratification. And with altogether, what we calculated, he's a ASA classification of 3, NYJ, 2 class, MET score of less than 3, frailty score of 3 to 4, a care score of 2 to 3, and a Euro score, as I mentioned, mortality score of 4.69%. So overall, he is a fairly moderate risk patient, and we have to plan our anesthesia accordingly. One more thing before I go ahead. In most of the cases, that we do in a day-to-day actual cases, we do not have, I personally don't do a Euro score. So what I do is I go through as my resident calls, and I go through the history. I wait for the bell to ring. I want to hear whether the patient has diabetes, and if the diabetes is uncontrolled, hypertension is uncontrolled, renal dysfunction, whether the patient requires dialysis, uncontrolled hypothyroid state. These are the conditions which you actually need to take care of, sort of optimize before you take the patient. Unless the patient is emergency surgery, you should not, take these patients. They should have adequate time to optimize them before taking. And also, if the patient is short and obese, as in our case, with loose teeth, he has a chance that he'll have a fairly difficult airway. And especially because he has left main disease and a 40% ejection fraction, you would not have much time, filling in inside the airway, putting in a tube. So your planning should be, adequate and beforehand. And especially if you have other, as in the Euroscore, redo surgery, emergency surgery, they all add to your anesthetic and overall patient risk. And this patient is also a heavy smoker. COPD adds to the risk, as we mentioned. So difficult breathing, prolonged ventilation, requirement of BiPAP. So a pulmonary review is very, very necessary. Also check for if the patient has regular alcohol intake, if it is a tobacco chewer, which increases the propensity of the patient having oral submucous fibrosis. And if the patient is on ARBs and ACE inhibitors, do stop them. OHS need to be converted into insulin before you take the patient. And the clopidogrel and aspirin, they are the dual antiplatelet agents which are given for all patients on stents. They need to be stopped, but do make sure that you have a bridging therapy with heparin at least. So Drug-eluting stents, till 1 year, you have to continue. You cannot stop these antiplatelet medications. And for a bare metal stent, at least a month, before you can stop. So if you have a patient with bare metal stent going for a elective surgery, you should postpone them. Or a drug-eluting stent, the patient is having, say on 6 months you have a lap chole, you should postpone the patient till 1 year. For emergency surgeries, you have to bridge them with heparin and hope for the best. There's a very high chance that they have impaired or incomplete re-endothelialization of the stent, and because of the hypercoagulative state of the surgical stress, the patient might have a stent thrombosis, especially with the all the increased risk factors of stent thrombosis, because the patient is 70 years of age, advanced age, he has diabetes mellitus, he has renal insufficiency, he is obese, has left ventricular dysfunction, and multiple disease. So all these are risk factors which increases the propensity of stent thrombosis. Now, before I proceed to the actual anesthesia part, conduct of anesthesia, just a couple of slides on heart failure. Most of the, including very senior people in the medical fraternity, I have heard, it's 60% ejection fraction, so the heart is good. So it is not necessarily true. Almost 50% of patients with heart failure would have ejection fraction of more than 50%. So, you have to keep this in mind. This is the latest classification from European Journal of Heart Failure, from the European Society of Cardiology. So HFpEF is basically heart failure with a preserved ejection fraction. So a lot of these patients who would have 60% ejection fraction still have heart failure. So these are the 4 stages of heart failure. Our patient has all the risks in stage A and stage B. So he is, for a stage A, patient does not have any symptoms. And the risks are hypertension, cardiovascular disease, diabetes mellitus, obesity, and so on. And our patient also has the risk factors for stage B, or a pre-heart failure, which is wall motion abnormalities, valvular heart disease, reduced LV systolic function. And he also has some symptoms, especially when he's walking longer, or taking a flight of stairs, he feels breathless. So he could actually be in stage C of heart failure. And he can, although he has not reached the final stage where the patient is orthopnic, with heart failure. But you should be aware that the signs and symptoms like breathlessness, reduced exercise tolerance, fatigue, tiredness, wheezing, etc., which he has, could be because of heart failure. And if you do a BNP or anti-pro-BNP, they might be above cutoff. But most of our records, as you see, we don't usually do anti-pro-BNP in the perioperative period. If you do, it's fine. If you don't, that's very simple baseline parameter which can help you is the E by E prime. It basically is a pulse rate Doppler. You get a 4-chamber view and put a pulse rate Doppler gate at the mitral inlet. You get the E and A, which is very common Doppler modality in the normal echocardiography. And you can use a pulse rate Doppler on the tissue on the lateral mitral annulus, and you can get a E prime by A prime. E by E prime ratio of more than 15 very strongly corroborates the pulmonary capillary wedge pressure of more than 15 millimeter mercury. So high pulmonary capillary wedge pressure is seen in patients who has heart failure because of, we call it high filling pressures. So a very simple modality can tell you whether the patient has a higher propensity of heart failure, E by E prime. Now, coming to the conduct of anesthesia. So the big question, although it's not a big question anymore, but I think still there's a group of sort of surgeons and anesthesiologists who basically think awake is a good technique, and a thoracic technique for awake cardiac surgery for intra and post-operative pain relief might be better than general anesthesia. But overall, the evidence that the regional technique has any conclusive advantage over GA in cardiac surgical patients, there's no concrete evidence. And in our practice, we use almost in every patient 1,000 mics of Bentley for adult patients, and within 4 to 6 hours, when we check the patient is bleeding or not, and in the ICU, once they are warm and stable, we comfortably sort of extubate them. And there's no, uh, in our experience, there's no need for a thoracic epidural if you are planning your analgesia properly with your IV agents. Now, this is where it started. There are several papers, awake coronary artery bypass grafting, utopia or reality, from Germany, and they claim that surprisingly, the awake CABG patients, the patients accepted the procedure pretty well, and they did very well overall. And this is a paper from Germany in 2011, published in the EACTA, European Journal of Thoracic Surgery. And they said that awake OpCab is a promising modality of ultra minimally invasive cardiac surgery. And almost all the patients were able to drink water and walk very soon after surgery, suggesting the potential of this protocol as 1 day or day surgery. So they were trying to promote 1 day surgery. You do it and you get it and you go back home, almost like a lap poly kind of a thing these days. So the thing against that is this is quite a significant number, 654 elective cardiac surgery patients in an RCT published in the top journal Anesthesiology in 2011, and they compared thoracic anesthesia with general. So 329 patients were allocated to general anesthesia versus 327 patients allocated to thoracic anesthesia, and they concluded that the study was unable to demonstrate a clinically relevant benefit of thoracic epidural anesthesia on the frequency of major complications after elective cardiac surgery compared with fast-track cardiac anesthesia without epidural. Given the potentially devastating complications of an epidural hematoma after insertion of an epidural catheter, it is questionable whether the procedure should be applied routinely in cardiac surgical patients who require full heparinization. Sorry. So, coming to monitoring and vascular access. So, what are the standard monitors that we use for a general anesthesia? So all the things that we use, basically we will use a ECG, pulse oximeter, and a non-invasive blood pressure. The only thing different for our cardiac surgery would be that we use instead of three electrode, we use a 5 electrode and a 3-lead ECG, which is lead 1, which is a representative of the lateral left ventricle, lateral wall of the left ventricle, lead 2, which is the inferior wall of the left ventricle, and V5, which is the anterior wall, anterior anterolateral wall. So we need to have these 3 leads on in every patient undergoing CABG because of arrhythmia or ischemia happening in any one of the walls of the LV. Of course, pulse oximeter and invasive blood pressure. Invasive blood pressure is different from, this is what is different from a general patient, a patient undergoing general anesthesia for other surgeries. And of course, we need to put a central venous line or a pulmonary artery catheter. So the big question is whether we need a PA catheter at all. We'll discuss this slightly sometime later. Now, the next question is, should you put in invasive lines, a CEP or PAP or an invasive blood pressure before or after induction anesthesia? There's no rule, largely individual practice and varies from center to center. But in our practice, using midazolam and fentanyl premedication and adequate local anesthetic infiltration, patients actually remain calm, and it's pretty easy to put in invasive lines quite comfortably. And the advantage of putting in invasive lines prior to induction anesthesia is that you can manage hemodynamics more conveniently, and they are more under your control, especially at induction if the patient becomes unstable. Your focus remains on, trying to manage the hemodynamics, not on putting invasive lines when the patient is very, very unstable, right? So cases where you should, especially those cases where you should put invasive lines prior to induction, if you're not having a practice of putting invasive lines before, at least if you have fixed output lesions like severe AS and severe mitral stenosis, a tight left main disease like in this patient with a 40% ejection fraction, with a tight 80% left main, and a significant LV diastolic dysfunction, I think it makes sense to put in the invasive lines before rather than later on once the induction has happened and the patient is hypotensive and unstable. So to PA or not to PA. So a PA catheter, I think a lot of residents over here would not have seen what a PA catheter is. So PA catheter looks like this. It's basically it's called a yellow snake, popularly call it a yellow snake. It is a 110 centimeter long catheter, which has a balloon tip. The balloon is supposed to wedge in one of the smaller branches of the pulmonary artery. So it goes. So this is SVC, this is IVC, this is RA. So it comes through the either intrajugular or a subclavian vein and through a sheath and goes through the IVC into the RA, through the tricuspid into the RV, through the pulmonary valve into the pulmonary artery, and it lodges into one of the radicals of the pulmonary artery and wedges over there. The idea is to give you some data which the conventional lines do not give you. It's like pulmonary capillary wedge pressure. As I mentioned before, the E by E prime is a surrogate of pulmonary capillary wedge pressure. So non-invasively, if you're doing the E by E prime, it's a fairly good, simple method of assessment of the pulmonary capillary wedge pressure using an echo. It also gives parameters like cardiac output, cardiac index, pulmonary mean systolic and diastolic pressure. Whether you need it in all patients is a big question. So the controversy, there's a huge controversy whether to do PA or not to do PA. We don't do PA in routine patients or stable patients. Only very selected group of patients, like patients undergoing heart transplant, very sick patients, less than 30% ejection fraction with severe diastolic dysfunction. These are patients whether you do a CCOPA, and this is another system, which is the transpulmonary thermodilation, where the technology is different. It is not a PA catheter; it's a normal central line, from where you can put in a cold saline, and the thermistor to look at the change of temperature is in the femoral artery. So the blood traverses to the right heart, to the pulmonary vasculature, to the left heart, and then to the aorta, and reaches the femoral artery. So this is called the PICO technology. Over here, this is a volume view system, and it gives you a lot of different indices like cardiac index, stroke volume variation, stroke volume, systemic vascular resistance, SCVO, so on and so forth. A lot of things together. But like for me, I don't need complicated technology, especially because I have access to the echo, which is a superior tool. But the problem of echo, I will come when I talk about echo. I'll talk about that also. But before I miss it, so this is the thermodilation curve of the pulmonary artery, the PSC, and this is a transpulmonary thermodilation curve. They might ask you in the exams, why is it so different? The thermistor is inside this is for the PA. The thermistor is is inside the heart, it's inside the PA catheter. So the upstroke of the cardiac output is pretty steep and early. For the transpulmonary PICO technology, the transpulmonary thermodilation technique, the thermistor is way down in the pulmonary artery. That is why it takes time to reach the femoral artery, and the curve is less steeper and more prolonged compared to the PAC. And so this is a technology how the PICO combines the pulse control analysis with this thermodilation curve and gives you a very accurate analysis of cardiac output as well as stroke volume variation and all the parameters that they give. Whether you need it or not is a big question. So this is 2013, the famous article by Paul Marek, and it published in the Annals of Intensive Care. And it is very funnily written as an obituary to the PA catheter. So as if he was a small boy when he was born in 1970 by H.J. Swan and William Gans. So the PAC grew rapidly, reaching manhood in 1986, where in the US, 40% of all ICU patients would have a PA catheter. But his reputation, however, was tarnished in 1996 when Connors et al. Said that he harmed patients, and this was followed by a randomized controlled trials which suggested that he was also unreliable and inaccurate in the measurements of cardiac output and everything, all the parameters that it gave. To make the matter worse, a dynamic assessment of fluid responsive like pulse pressure variation, stroke volume variation, and leg raising made a mockery of his wedge pressure. While a handful of die-hard followers continued to promote his mission, the last few years of his existence were spent as a castaway until his death in 2013. So Paul Murray claims that in 2013, all the good things the PA catheter had was gone. So the PA catheter went into oblivion. How true that is I doubt. because I still think when it's very sick cases like a heart transplant patient and patients with less than 30% ejection fraction, as I mentioned before, the left heart and the right heart behave totally different. So you have to know both the left heart and the right heart pressure. So in those selected cases, although the debate, the pro and the con goes on, you can read these articles in 2021 in Annals of Cardiac Anesthesia, interesting articles. But I think it still has its use in very selective cases. Coming to the anesthetic part, how would you sort of induce the patient? Again, it's an individual choice how you induce. There's no clear-cut advantage of one over another. I have colleagues who induce with thiopentone, propofol, ketamine, midazolam, etomirate, and a variety of cafeteria choices. But the most stable agent, if I have to name two, one is etomirate amongst the IV agents, the most stable, and the other is which I love to use is the sevoflurane, which is a non-inhalational agent. So you can use both for induction as well as maintenance of anesthesia, which I do, including heart transplant patients. And we conducted a recent study I'm going to show you later on. And etomirate versus the study was about etomirate versus sevoflurane in patients with good LV systolic function. Before I come to that, there are some problems that were raised by raised for etomirate. Actually, etomirate does affect adrenal function. It has been proven, but whether it affects cardiac surgical patients is the big question. So this is 2013, I think, yeah, respiratory care. In a critically ill patient, induction with etomirate is hypothesized to be associated with an increased risk of mortality. Previously published studies, RCTs, suggest a modest trend towards an increased risk of death among etomirate recipients. So in this study of critically ill patients requiring endotracheal intubation, etomirate administration was associated with a trend towards a relative increase in mortality. So for critically ill patients, especially with sepsis, there's a sort of allegedly etomirate is harmful, but this has not been proven in cardiac surgical patients, especially those selective patients undergoing cardiac surgery. So this is 2014 Anesthesiology, the top journal with the highest impact factor, where they say that etomirate use and post-operative outcomes among cardiac surgery are fairly good. So this is a retrospective analysis of patients between 2007 and 2009, and 3,127 patients who went on for elective cardiac surgery. 62% of them received etomirate, and they said that there's no evidence to suggest that etomirate exposure was associated with severe hypotension, longer mechanical ventilation hours, longer length of hospital stay, or in-hospital mortality, and they concluded that etomirate should remain an option for anesthetic induction in elective cardiac surgical patients. Even this study in British Journal of Anesthesia in 2011, I think, yes. And it's a RCT involving 100 patients undergoing elective cardiac surgery, and they induced with, I think, etomirate versus propofol. Yeah. And they said that, in conclusion, a single bolus of etomirate blunts the hypothalamic pituitary adrenal axis response for more than 24 hours in patients undergoing elective cardiac surgery, but this was not associated with an increase in vasopressor requirements. So, is volatile anesthetics safer or better in any way? So, this is one of the studies in NEGM, and they compared, the inhalational agents with IV agents, and they found that if you're talking about long-term mortality and morbidity, the claim is from this because the volatile anesthetic agents have cardioprotective effects. So they wanted to find out whether this cardioprotective effects has any long-term survival benefit. So among patients undergoing elective CABG, anesthesia with a volatile agent did not result in significantly fewer deaths at 1 year compared with total intravenous anesthesia. So mortality benefit is not there. So overall, this is 2021, one of the studies where etomirate used for rapid sequence intubation, and patient had sepsis as a background. But those patients who had sepsis actually had a tendency, although not statistically significant, the patients who were septic had a tendency towards development of adrenal insufficiency. But overall, etomirate has been established. If your patient is having no infection, it's elective cardiac surgery, it is an accepted agent. Even in heart transplants, we use etomirate. So I compared, not me, in fact, my student Asim, he, as his thesis, he compared sevoflurane versus intubated for anesthetic induction in coronary artery patients. I'm not going into the details. We did 50 patients on each group, all in 35 and 75 years of age, good ejection fraction, more than 50% with a normal sinus rhythm. And we found out that intubated and sevoflurane used in reducing agents in patients undergoing elective CABG with good ventricular systolic function produce comparable hemodynamic environment. And intubated offers a faster rate of induction compared to sevoflurane, and there's no difference. There's no difference in airway complications between the group. So maintenance of anesthesia is I combine both sevoflurane and TIVA. In the background, propofol runs at 15 to 20 ml per hour for adult patients with an entitled CO target of sevoflurane. And I start with a 250 mics at induction of fentanyl. I add another 250 before the sternotomy. Overall, 1,000 mics for adult patients, 1,000 mics of fentanyl. And hemodynamics is monitored, maintained with norepinephrine, dobutamine, and if necessary, epinephrine, milrinone, etc. Now, for cardiopulmonary bypass, there are some prerequisites we need to, as an anesthesiologist, you need to sort of be aware of. The ACD target, you have to give heparin and ensure before the patient goes on bypass. The ACD should be 480, at least more than 400 before you let the perfusers go on CPB. And on the CPB, you need to add something to provide anesthesia because it is off the anesthesia machine. So I love to give propofol at the rate of 20-25 ml per hour. You can also choose sevoflurane, but I'm not really sure how to monitor if you're giving sevoflurane in the CPB circuit, how to monitor that because there's no entitled SIBO over there. And try to maintain a mean arterial pressure of more than 50, if necessary, with a vasoconstrictor when the patient is on full flow, and maintain a hematocrit of more than 21. While coming off bypass, ensure that the top of midazolam fentanyl is given and the propofol is running at higher rates, especially when the patient is being warm, right? So from the time that the patient is being warm till the patient is weaned off CPB, because this is a time where the patient awareness is highest. The chances of patient awareness is pretty high at this time when the patient is warm till the patient is coming off bypass. Ensure that the temperature has reached around 37 degree and the hematocrit is more than 21, as I mentioned. If it's less than 21, we keep a target of 8 gram per cent, hematocrit 24 off pump. So ask for Paxil beforehand and warm the blood. Look for, ensure that there's no acidosis, ensure that the ABG is fairly within normal limits. If there's any hypocalcemia, hyperkalemia, correct them beforehand. Ensure that the patient is in normal sinus rhythm. Those who are in sinus rhythm should come back to sinus rhythm unless they had a rhythm like AF for a large LA with a mantle stenosis and so on, where unlikely the AF is going to convert to sinus, but at least you can do rate control with beta lock, which is a beta blocker. And before coming off, also re-zero the lines, start ventilation once the perfusion starts filling the heart, and once off, the bypass, and you're giving protamine, be aware of the chances of significant facilitation of visoplegia, where you should be vigilant about that, and if necessary, you should maintain with fluids and inotropes and constrictors. So the guidelines for perioperative care in cardiac surgery, this is enhanced recovery after surgical society recommendations. I think this is JAMA 2019. I'll just highlight the ones which are the strongest recommendations. So for groups where ICUs and for the teams where they are facing a lot of problem with MRSA, intranasal decolonization with mupirocin 5 days beforehand, before the patient goes for elective surgery, it is recommended and gives a very good result. We don't have much of MRSA, so we don't use this protocol, but all the rest four we very stringently use. So we use cefuroxime, the second generation cephalosporin, 30 to 60 minutes prior to surgery. We use clipping, not shaving, for preparing the patient for surgery. And we use a chlorhexidine and alcohol-based solution for skin preparation before surgery. And we remove the wound dressing after 48 hours very diligently. So the last part of the talk is monitoring with echo, and the last edition of Kaplan, in fact, if you look at the front page, it mentions the echo era. It has a tremendous impact, and now it's almost, we cannot think of cardiac surgery without doing a transcatheter echo. So why is it so important? Because the biggest advantage of TE over other monitoring tools like the CCOPA or the PICO technology is that although they give a plethora of hemodynamic information like the cardiac output, cardiac index, SVR, SVRI, stroke volume, cardiac output, extravascular lung water, etc. But it does not give anatomical information. It cannot tell you exactly whether you have a worsening MR or a TR or a dissection or a tamponade. I'll give you examples. I'll show you examples just to prove the point. The disadvantage of echo as a tool in the ICU is that it's not a continuous monitor. A continuous tool like a CCOPA or a PICO-based technology, example EV1000, should be used in a sicker subset of patients. So the T, actually, we don't have time for going into a detailed assessment, but it gives you a very fair idea of the 7 hemodynamic states, whether the patient is normal, hypovolemic, vasodilated, has a primary systolic dysfunction, primary diastolic dysfunction, or a combination of these two, or a RV dysfunction. So just by looking at them, I can, I don't need to have complex data to tell that this is a very good heart. There's no wall motion abnormality. The volume status is good. Systolic function, diastolic function, everything can be made out. So this is parasonal short axis, all the 4 views of the transthoracic echo. This is the parasonal long axis view, the parasonal short axis view, apical forechain and a subcostal view of the heart, showing a normal contractility and function. And on the contrary, this is a patient. Can anybody tell what this is? So this is, if you look at the LV EDV, the cutoff is around 100. So 147, this is a hugely amount, it's a dilated heart with a good amount of volume inside, but the contractility is not bad. So this is a Simpson's method where you calculate the endostolic volume and then systolic volume, and from that you can calculate the ejection fraction. It's around 50%, fairly good ejection fraction. Even if you look at the diastolic function, it's not so bad. But if this patient is for any reason hypotensive, the only thing I would probably do is not to give fluids. I'll probably start with a norepinephrine. So visual estimation is excellent. You just look at the heart and you know what it is. For example, this is a good LV with ejection fraction around 50-60%. In this case, this is more than 70%. Is a kissing ventricles. You see the heart is empty. I'll give fluids in this case. In these 2 cases, the ejection fraction is too bad. So it's probably 30%, less than 30%. And these are probably waiting for heart transplants. This is one of the perioperative patients that I had, and this gives you an example that how one part of the heart can be empty, the other part of the heart is full. So LV is full, the RV is empty. It's difficult to deal with this scenario because you need to give fluid for the RV is empty. But if you give too much fluid, this is LV is full, and then there's a hypokinetic LV which is around 35% ejection fraction, maybe 30% ejection fraction. So if you look at this kind of heart, you know what to do. You should not give too much of fluids. So compared to this patient where it is both the RV and the LV, you can see it is absolutely empty, right? So the first thing, once you notice that this is a kissing of the papillary muscles, once you notice this, you know what to do. You have to give fluids, right? And our patient is supposedly having a aortic valve stenosis, and he has a bicuspid valve. This is a cartoon where you can see this, a normal trileaflet aortic valve, and later on this part is an aortic stenosis. But this is a trileaflet valve. I'll show you what a bicuspid valve. This is a normal bicuspid valve. This is a young male around 40 years of age who was undergoing CABG. There was an incidental diagnosis of a bicuspid valve. The valve was absolutely fine. We did nothing with it. Just mentioned in the echo report that he has a bicuspid valve. On the contrary, this is one of the patients who was undergoing AVR. This 65-year-old gentleman has a severely calcified, bileaflet aortic valve, and he underwent AVR. So this is the criteria for a severe aortic stenosis. See, the gradient more than 40 mm, the mean gradient of more than 40 mm of mercury. And this is a dense portion of the envelope. This is as the blood goes through the LVOT and the aortic valve, You can get the gradient. And once you measure the gradient, then the gradient is the mean of more than 40. That is a classification of severe aortic stenosis. But the problem is, in our patient, the ejection fraction is 40%, or even say it's somewhere between 35 to 40%. And even if he has a severe stenosis, it will behave like a mild or moderate, and that is called a pseudo severe. That is where the perioperative echo assessment is very important. You look at it on a 2D or a 3D, and you judge and tell the surgeon that this is a severe aortic stenosis, but it's looking like a not so severe because the ejection fraction is 40%. So this particular patient, I gave you a scenario of actually underwent a CABG as well as a aortic valve replacement, a combined surgery. And before we finish the talk, I think this discussion is very pertinent, and a discussion without which is better, off pump versus on pump. The debate goes on. So just if you ask me a question, then what is better? So this is 2019 circulation published in a leading journal, and they found that for elderly patients, the outcome difference between off pump and on pump is not much, probably because they don't live longer, right? So off pump and on pump coronary artery bypass grafting provides similar long-term outcomes in elderly patients. Unless until there's incomplete revascularization, the surgeon did not complete it, probably because of technical difficulty or whatever, then the five-year survival rate would vary between the two, depending on what is the rate or the degree of incomplete revascularization. But overall, in elderly patients, whether you're doing off pump or on pump CABG, it does not make a difference. But in the longer term, probably, again, the debate goes on. This is the latest meta-analysis from Heart, Lung, and Circulation published in 2020, and they compared off versus on-pump CABGs, grafting long-term survival. Off versus on-pump coronary artery bypass grafting long-term survival is driven by incompleteness of revascularization. So the thing is, like, if you are a bad heart and you're doing off-pump surgery, and you tend to sort of skip, you don't have time and it's more risky. So that could be a possible reason why the either it is incomplete or the quality is not so good. Whatever speculation would not help us. But overall, it seems that off-pump CABG is associated with significantly higher rates of all-cause mortality rate and a long-term follow-up. These outcomes demonstrate a temporal relationship that may be driven by a greater requirement for repeat revascularization at 1 and 5 year follow-up. Maybe there's a tendency which shows that on-pump CABG, especially for long-term survival, is better. But then again, it is a matter of debate. It is not clearly proven as of date. So to summarize, how to plan anesthesia for a 70-year-old gentleman scheduled for CABG. So to summarize, I would say assess the risks, stratify the risks, and plan the anesthetic course accordingly. Invasive lines put under adequate sedation and local anesthesia prior to induction may be helpful if patient becomes unstable during the course of induction. Both sevoflurane and etomidate can help in smooth and hemodynamically stable induction. Starting a low-dose infusion of inotropes and vasoconstrictors, I usually, before inducing my patient, I start the NORAD at 3 ml 4/40 solution and the dobutamine 250/50 at 3 ml. So both 3 mls per hour, 2 to 3 minutes before induction, just to increase the inotropy and increase the afterload a little bit to counter the effects of the anesthetics. And it does a good job. In my practice, I rarely have a crash. So starting a low-dose infusion of inotropes vasoconstrictors to nullify deleterious effects of anesthesia may achieve a smooth and stable induction. Inhalation and or TIVA both can be used for maintenance of anesthesia in the off-pump or on-pump scenario. Invasive BP, CP, and intraoperative TE is all you need in most cardiac surgical patients. Only the highest risk patients undergoing long and complicated procedures like heart, lung transplant, etc., would need additional monitoring, examples of CCOPA or a PICO, etc. Assessment with intraoperative TE has changed the practice of cardiac anesthesia, especially in the last 2 decades. Thank you so much.